obstruction. The reason for his acute kidney disease is, I just dragged you inside the pit. I want you to fall. You fell by yourself, right? We all should understand that if one kidney is enough to sustain a normal urea and creatinine, if a unilateral obstruction is going to cause an increased creatinine, understand there is some problem with the other kidney also. Correct? The other kidney is working well. The GFR is already more than 50 ml per minute. If the combined GFR is 100 ml per minute, okay? Unilateral obstruction should never cause renal failure. Correct? Right? So if somebody is going to have an obstructed system to both the sides or obstruction to a solitary functioning kidney, they can have renal failure. Unless otherwise, unilateral obstruction, another kidney is functioning normally, should never cause azotemia. One. So, what is a pre-renal cause? We all confuse this. I'll discuss about this subsequently. We all confuse between pre-renal azotemia and acute tubular necrosis. If somebody is going to have any condition that is going to decrease the blood flow to the kidney, the commonest conditions are severe vomiting, severe diarrhea, blood loss, burns, and so on. You have a decreased blood volume, a decreased blood supply. One other condition is congestive cardiac failure, where though there is an increased load what the heart can handle, there is a decreased cardiac output. So because of it, the renal blood flow is reduced, and these are the commonest causes of a pre-renal condition. So we have a pre-renal condition, you have got a post-renal condition, that is obstructive urine. So we have intrinsic renal disease, as I told you before. The disease can be disease of the glomerulus, disease of the tubules, disease of the interstitial. That's how we nephrologists can classify. But as far as you are concerned, you take a patient's history, ensure that patient is not having any of the pre-renal conditions, which is very easy to diagnose. Do an ultrasound, ensure that there is no obstruction to the urinary tract. And in case if they are not there, I've told you what is a glomerular disease, how do you differentiate tubular interstitial disease. We can to some extent diagnose what is the problem. I think I've told you this. Any patient who is admitted in the hospital, the commonest reason for an acute kidney injury is sepsis. You should ensure that patient, they may not have anything else. A subtle increase in total count, especially in an elderly patient, should tell you that there is evidence of an infection. You need to look on to it. Okay? Oops. If you take patients with sepsis, many of them have acute kidney injury. If you take many patients with acute kidney injury, most of them have sepsis. Right? That's like husband and wife put together. Right? So consider that there are a lot of patients who are admitted in the intensive care units. 2/3 of them develop an acute kidney injury. Most of them, if not all, will be at increased risk of death because of acute kidney injury. If you see why patients die in the intensive care unit, one of the reasons, it may not be sepsis related, it may not be cardiac related, it may not be liver related. It can be kidney related itself. The patient can die because of acute kidney injury, any of the complications of acute kidney injury, patients can die. So we do not want somebody to die because of acute kidney injury, because it can be identified, it can be prevented most of the times. Because many times patient comes to you with acute kidney injury, that is different. But when somebody gets admitted in the hospital who was normal, you do a hysterectomy, and patient gets on to an acute kidney injury, that is unacceptable, that you would like to avoid. Okay, this is a question what all of us confuse ourselves to a great extent. We have had questions from England as well. Correct? How do I, okay, now you make a diagnosis of an acute renal failure. Presume that somebody has got with vomiting, somebody has got admitted in the hospital, somebody's blood pressure is low, and you want to treat. You made a diagnosis of an acute kidney injury. You thought it's risk stage, injury stage, all of you are very clear. It is not chronic kidney disease. You have made an ultrasound, everything is fine. Now you want to treat this patient. The question is, how do I decide to give IV fluids to a patient with acute kidney injury? Should I restrict this intake? Should I give plenty of fluids? We were taught, right? The previous day's output is 500 ml for the insensible water loss. Does a high urea creatinine warrant restriction of salt and water? These are some of the questions what all of us have doubts at every point of time. I don't know who invented this concept of previous day's output with 500 ml. Presume a situation where somebody is having acute gastroenteritis, is vomiting, is having significant diarrhea, and he continues to have that, his blood pressure is still low, and the last 24 hours urine output is 500 ml. If you apply this formula, you give only 1 liter next day, and the patient continues to be in dehydrated state. So the previous day's output of 500 ml is not applicable when somebody is significantly dehydrated. Think of other situation where somebody is in congestive cardiac failure, where you push enough diuretics, somebody is passing 3